So it's my pleasure to introduce the last session, which is the flu session. I'm sure it's your pleasure as well. I'd first like to acknowledge all of the work group members, and I particularly like to acknowledge Lisa Grohskopf, who was as a PHS member working very hard all during the shutdown to try to get all of this material ready for us today. There have been a number of developments since the June ACIP meeting. The first, of course, is the publication of the 2013-14 ACIP influenza statement. And this year, that was no small task, because in addition to the usual summary of the virus strains for the 2013-2014 vaccine, there's a summary that you'll find there of 6 recently approved vaccines, 4 quadrivalent vaccines, and 2 new trivalent vaccines, Flucelvax and Flublok. And there was also a revision of the egg allergy statement to include Flublok in egg allergic individuals who are aged 18 to 49 years. We also heard about the licensure of Flulaval quadrivalent for children and adults ages 3 and above, and a new age indication for Flulaval trivalent, such that it was age de-escalated so that now children ages 3 and above can get it in addition to adults. We also heard a preliminary discussion of the Fluzone high-dose vaccine, and you'll hear more about that today. So today you'll hear 3 talks, and I should say that only one of these has the flu work group heard because of the shutdown. We have heard the third talk that you'll hear about, the presentation by Sanofi of the high-dose vaccine efficacy trial results. But in addition, we'll hear today a flu surveillance update from Lisa Grohskopf and an update on influenza vaccine distribution and coverage for the last flu season from Jim Singleton. So at this point, I'll turn it over to Lisa.
Okay. This will be a brief update of domestic influenza surveillance for the season thus far. I should mention this is information that comes from FluView, and it is for the most current report, which is week number 41 in our calendar. That's the week of October 6th through 12th, 2013. First, this is the map that summarizes a geographic spread of influenza activity that is summarized through weekly report by state and territorial epidemiologists. This is, again, a geographic spread and is not intended to be interpreted as an index of disease severity. We have one region, that's Puerto Rico, that reported regional activity. 3 states for this particular week reported local activity, those being Texas, Mississippi, and South Carolina. And most of the rest of the country reporting either none or sporadic activity, with the exception of Nevada, which did not submit a report. For the same week, week 6, this is a summary of influenza positive tests that were reported to CDC by the WHO and National Respiratory and Enteric Virus Surveillance System laboratories that are located throughout the United States. These labs report the number of specimens submitted and tested, and the percent, the ones that are positive for influenza. As of for week 41, we have 3,534 specimens tested, of which 166, or 4.7%, were positive. The breakdown by type is summarized in color on the bars, with 91% being flu A, 9% being flu B. Among the A's, 25% H1N1 2009, 6% AH3N2, and 68% not subtyped as A's. This is data from ILINet, which is the U.S. influenza-like illness surveillance network, which is a network of over 2,900 healthcare providers that report on outpatient visits and basically report the proportion that are for ILI, which is defined as fever greater than or equal to 100 degrees, along with either a sore throat or cough that can't be attributed to another known cause other than influenza. This slide has multiple seasons on it, and the current season that we're talking about now is represented by the line with the tiny triangles way off to the left. That's all we have for the season so far. It is fairly early, but for week 41, 1.1% of visits were reported to be due to ILI. This last slide is the pediatric death summary slide. Pediatric deaths due to influenza have been reportable since 2004. This slide summarizes data since the 2010-11 season. For 2013-14, no pediatric death reports have been received yet. The total for 2012-13 was 165 cases. That's all I have for this, but happy to take any questions.
Looks like that was a very complete report there. Any questions at all? And if not, we can move on to the discussion of the vaccination distribution and coverage.
Thanks very much.
Hello, I'd like to talk about the vaccine coverage results from the 2012-13 season. These results were released on September 27th. Just an overview for the 2013 season. It's the third season in which we've had the universal flu recommendation and the third season after the 2009 pandemic. And the 2012-13 season began early, was moderately severe, and duration was longer than average. And there were spot shortages of flu vaccine reported in January. I just want to give you an update on the Healthy People 2020 objectives for flu vaccination. It has not been widely publicized, and it's not updated on the Healthy People website yet, but the 10 objectives for different groups were consolidated into 4 groups, one for children, one for adults, one for healthcare personnel, and one for pregnant women. The target was 70% coverage for children and adults and 90% for healthcare personnel. For pregnant women, there's no target set because that was moved to a developmental objective, which means that we're evaluating different data sources to determine the best one to monitor coverage for Healthy People 2020. We will continue to monitor all the populations that were looked at before. So this slide shows the cumulative distribution of flu vaccinations for different seasons. In the red is the 2012-13 season, 134.9 million doses distributed similar to the prior season. And then for the current season, you can see that about 73 million doses were distributed by September 20th. Just the data methods we're updating. We produced interim estimates in November of 2012 based on early season data. For here, I'm reporting survey data for the general population. It's very large samples of children from the National Immunization Survey and from the Behavioral Risk Factor Surveillance System. And then in April 2013, we conducted internet panel surveys of healthcare personnel and pregnant women, 1,900 and 1,700 sample size each. Those are published in the MWR. So this shows recent trends based on the NIS and the BRFSS. So for children, we see an increasing trend reaching 57% in the 2012-13 season. For adults, 42% in the 2012-13 season overall, about 45% of the population. Just showing, this shows the cumulative uptake of vaccine by month for children on the left, adults on the right. And you can see that for children, we had about 5% increase at the end of the season compared to the prior season. And that increase occurred primarily in December and January. For adults, there was a 2.7 percentage point increase about the end of the season. Less pronounced, but that happened more in January and February. So this is a summary slide for children. For the 2012-13 season, 56.6% of children reportedly received one or more doses of flu vaccine, a 5 percentage point increase from the prior season. As we've seen in prior seasons, vaccine coverage decreases as age increases. So you had a high of 77% in the current 2012-13 season for the 6 to 23-month-olds and 43% in the 13 to 17-year-olds. The increases from the prior season were more pronounced and statistically significant for the 5 to 12-year-olds and the 13 to 17-year-olds, a 4 to 9 percentage points increase. This is data. We're looking at full vaccine coverage now from Sentinel IAS sites. 2012-13, there were 6 sites represented here. The prior season, there were 8 sites that we measured. But you have in the dark blue bars receiving 1 or more doses and fully vaccinated in 2 different ways. The simple way in blue, which is just based on vaccine history from 2010-11 forward, and then the more complicated approach that can eliminate some of the children who need 2 doses in the purple bars. But we see that the ratio of full coverage to fully vaccinated based on the complicated approach is about 69%, 73%, 74% respectively for the 3 age groups. So a little more than 2/3 of those that got 1 dose were actually fully vaccinated. And you see for the simple algorithm, you got for the 5 to 8-year-olds, you had a difference of 8.8 percentage points from 20 to 29% when you use the simple algorithm versus the one that uses data of vaccine history prior to 2010-11, and that only occurs in the older age group. Now switching to adults, we see 41.5% of adults 18 and over reported flu vaccination for the 2012-13 season, again about a 3 percentage point increase from the prior season. As we've seen before, vaccine coverage increases with age from a low of 29% in the 18 to 49-year-olds and 31% for the 2012-13 season, and then 66% for the older person 65 and older. And the increases were statistically significant in all the age groups, ranging from 1 to 3 percentage points. And when we look at persons 18 to 49 with high-risk conditions, their coverage was higher than all of the persons 18 and over, 18 to 49, 40 versus 31%. And we've continued to see a wide variation in flu vaccine coverage for children and adults by state. So on the left, the range was 44 to 82% among states for children, 31 to 53% for adults. And so you generally see that coverage in children is higher than adults by state as well as nationally. Now switching to racial ethnic differences in coverage, on the left we have children for the 2012-13 season. So for non-Hispanic whites and American Indian Alaska Natives had about similar coverage at 53-54%. Coverage in all the other age groups was higher and statistically significant, ranging up to 66% in Asians. For adults, coverage for Hispanics, other multiple races, and blacks was lower than coverage in whites. Again, we've seen long-standing disparities in blacks and Hispanics compared to whites for adults for flu vaccination. Now switching to healthcare workers, this shows the trend over time using the National Health Interview Survey, which is in blue, and an Internet Panel Survey in the more recent years in green. And they're both trending upwards. You can see that the Internet Panel Surveys tend to get slightly higher estimates, but they are trending similarly. Now, the Internet Panel Surveys also allow a timely way to look at flu vaccine coverage by different occupations and work settings among healthcare workers. And so here you see a graph from the NIVW article, and coverage at the highest you have physicians, generally increasing in all occupation groups, but the highest coverage in physicians at 92% in 2012-13, 89% in nurse practitioners and physicians' assistants, and 85% in nurses. And the lowest was in non-clinical workers at 65%. Now looking at it by work setting, highest coverage was in hospitals at 83%, 73% in physician offices and clinic settings, and the lowest 59% in long-term care facilities. Generally, the trend has been increasing, but for long-term care facilities, it's sort of bounced around over these seasons. And there's more information in the MNWR article. There's the prevalence of different workers and settings being under requirement for vaccination, which is highly associated with high coverage. Also with availability of vaccine at the work site. So those are strongly associated with vaccination. So switching to pregnant women, we have multiple sources for pregnant women. We've got BRFSS data here in blue, internet panel surveys in the purple, and we have PRAMS data for selected years. For the data where we have time series, for BRFSS and panel surveys, we're seeing kind of an increasing trend, higher coverage than we had in prior years before in 2009-10. And it's not evident here, but in the 2010-11 season, when we looked at the PRAMS data from 18 states, we got the same estimate as we got from the Internet Panel Survey, restricted to those same 18 states. So from the Internet Panel Surveys, about half of women who were pregnant anytime during October 2012 through January 2013 had received a flu vaccine before or during their pregnancy. And this is results from the Internet Panel Survey. Again, 50.5% overall vaccinated. When we asked if they received a provider recommendation and if they received a provider offer for vaccination, those that got both, 71% were vaccinated. If they just got a recommendation but not an offer, it was 46%. And if they didn't get either, then it was 16% vaccinated. And this was consistent across socio-demographic groups, and even among, this pattern was seen among those with a negative attitude towards vaccination. So place of vaccination, this is data we reported back in November of 2012. And generally for adults and children, provider medical places are the most common. For children, about 6% vaccinated in schools. And for adults, we see 18% vaccinated at pharmacy or store and 17% at the workplace. So in summary, flu vaccine coverage for the 2012-13 season increased 5 percentage points from the prior season among children, higher increases among the older children. Coverage for adults increased 3 percentage points, increases in each age group. And among children, coverage was higher than non-Hispanic whites for Asians, Hispanics, blacks, and children of other or multiple races. Racial ethnic disparities among adults persisted, saw wide variation in coverage among states, maintained last season's increases for pregnant women, increased coverage for healthcare personnel, and we also are showing that there's wide variation among healthcare workers by occupation setting and the policies toward vaccination in their facilities. Most common places for vaccination, again, were medical settings. Some of the limitations, tracking trends by season is complicated by multiple data sources with different timeliness and methods. We have an NIVW surveillance summary, summarizes data for the 2010-11 season, but also goes into detail describing the different data sources and their characteristics, and that is scheduled to be published tomorrow. There's a change in the definition of vaccination status for pregnant women in the Internet Panel Surveys. We included vaccinations in July, and we did that too for the general population, counting July vaccinations. And this year we excluded vaccinations received after pregnancy. It doesn't really change the conclusion that coverage is about half, 50% in pregnant women. Of course, there's all self-reported vaccinations not validated by medical records. We did estimate more people vaccinated than doses were distributed, so we generally know that these estimates are on the high side, but they're still very useful for tracking trends. And survey estimates may not be representative. Telephone survey response rates are low. That might also affect the estimates. And we're continuing to evaluate the Internet Panel Surveys for representatives and other characteristics. So recommendations are to increase flu vaccine coverage among all groups, reduce disparities in coverage among adults, and implement proven interventions to increase coverage. They're listed here. These are from the community guide and include also using immunization information systems, which is one of the more recent recommendations. This information is all in more detail at FluVax View. And just about the upcoming season, National Influenza Vaccination Week is December 8th through 14th. And we are planning on releasing data from November for the general population, for healthcare workers and pregnant women sometime during that week. I want to acknowledge all the people who collected the data, did all the work that I summarized today, and in there. Thank you. Do we have time for questions?
I think there is time for questions. Dr. Bennett.
Thank you for that excellent summary. And I think many of us remember when the immunization rate among healthcare workers was abysmally low. So these data are really, really exciting. My question is, do we have any data about decreased absenteeism or any kind of outcome data among healthcare workers that would be useful to convince other employers to engage in more aggressive vaccination campaigns?
I don't think CDC systematically collects that type of data, but there might be others who know of some studies. I don't know, Dr. Brzee, if you...
Yeah, our studies, the studies that we do annually for vaccine effectiveness don't measure absenteeism among healthcare workers, obviously. There have been studies in the literature which have described decreases in absenteeism among healthcare workers as a result of vaccination policies, but none from CDC studies at least.
And I'd also like to just jump in here and just mention that Dr. Farouk Ahmad has published a systematic review on the effect of healthcare worker vaccination in reducing transmission. And so that came out, I believe, this summer. I don't have the citation, but it was a very nicely done report using GRADE. Dr. Foster.
Thank you for the vast amount of information that you have presented here. I would be remiss if I didn't point out, though, while not showing on the graph, pharmacists were the number 2 group that actually had the vaccination rates highest.
Yes, those are split out in the NIVW article for those who want to look at that.
I have Dr. Karron.
So thank you. I actually have 2 questions. One goes back to your slide 7, where it's actually cumulative vaccination for adults and children. And the question that I have about that is, there's this, particularly there's this tail for children from November on. And does that reflect complete immunization and maybe some of the youngest children getting a second dose? Or is that a first dose? And if it's a first dose, I know I heard a lot from pediatricians in my community about inaccessibility and shortages, and do we know how this might relate?
Well, for this graph, this is cumulative percent, so this is for the first dose reported. For children, we do ask if they've gotten multiple doses and ask the month and year of each one, but we're reporting here just the first dose.
Okay, and so then do we know how this relates to vaccine supply?
Dr. Shukat.
I think there's a couple factors to roll in. One is that early December, of course, we do the National Influenza Vaccination Week events, and last year, the first day of that, I believe, there was a press conference that Dr. Frieden did that highlighted that we were having an early bad season, and we think that actually was fairly effective in raising demand. Before that, there was increased demand in a number of areas that were seeing that early disease. The supply availability, I think there was that other graph where supply availability was pretty early last year, but of course some formulations are always, you get them later, and we do, even when there's generally good supply. The particular formulations and particular practices may not get all that they want. I mean, I think you had the one of the distribution, rather, where you can sort of see that most of the doses had gone out by November, but that doesn't necessarily mean all the particular doses that you want.
Can I just ask a follow-up?
Yes.
Sorry. Just one follow-up, and that actually has to do with the healthcare workers. So what I really want to know is, what are we doing really, really, really right with nurses? So we went from 70% to 85% in 2 years. I don't know if it's carrot or stick, but probably stick, I agree, probably so. But it's interesting that the non-medical professionals are clearly lagging behind, and are there policies or procedures that we should be putting in place to try to have those increases as well?
Ms. Hayes.
To address the increase in nurses, I'm going to have to give the CDC credit, because they gave a grant to the American Nurses Association a few years ago to increase vaccination among nurses, and so it was a big project that we worked on for a couple of years. And I know that there are a lot of hospitals that are now requiring that employees be vaccinated. And when you look at the non-clinical personnel, I'm wondering how many of those are working in personal care homes or nursing homes where they don't have the same kind of push that hospitals have. So that may be part of the answer. I also had a question about the internet survey for pregnant women. Inherently, I think it's a self-selected small population of pregnant women. The pregnant women that I care for, a lot of them don't have access to the internet, so I always feel like that should be a caveat in that report. And I'm curious if you ever collect data on what their insurance is and whether or not they have Medicaid or private insurance.
We do ask about health insurance status on the survey. I think there are some estimates by health insurance status in the NIVW article. I'm not sure. I'd have to check, but we do collect that and we can look at that.
I know that 60% of the births in Georgia are Medicaid births. So, I mean, that's 60% of women are low income. So, and a lot of them may not have access to the internet. So I wonder if I wish that we could capture that population and find out what their vaccination rates are.
Yeah, I mean, we have, the BRFSS, we only asked if you're currently pregnant, so we took December through February interviews, and a woman currently pregnant during that time would be in the target population, and we could look more at that data source. The PRAMS data is state-specific and not in all states, but has a lot of rich data that can be looked at, and I think there are some. I think there was an article that just came out from Massachusetts that looked in detail at factors associated with vaccination among pregnant women. It's either coming out or just did. But yeah, that's, the internet panels, they're not going to include someone who doesn't have internet access. And what we've done is try to compare to other surveys, the PRAMS being one and BRFSS being another, and they're generally tracking the same. And we added some questions to the National Health Interview Survey that we have that data to look at. So we're trying to see the best way and evaluate these potential biases.
Dr. Schuchert?
Yeah, I was just going to say, one of the incentives that's operating recently is in acute care hospitals is CMS incentive pay for reporting healthcare worker vaccination. So, the improvements in physicians and nurses and nurse practitioners and so forth might be linked with that. The pharmacists are doing a great job, without that kind of incentive.
And it's possible that increasing number of facilities are having requirements, but I don't want to, that's just something we can look at with the data, but I can't, we haven't analyzed it here to show you there, but that's also another hypothesis that we can look at. We do, for the long-term care facilities, see that a lot fewer of those employees are in facilities that do have a vaccine requirement, say, compared to hospital employees.
Dr. Bikini?
I was going to ask, of the doses of vaccine distributed so far this year, do we have an idea of the relative number of quadrivalent versus trivalent, and particularly whether it's quadrivalent's available for younger children, VFC program?
I don't have that information. I don't know if Jeannie Santoli would have any more if she's here.
Dr. Schuchert?
Yeah, just a reminder that all of the LAIV is quadrivalent, and so the VFC program purchased quadrivalent and trivalent LAIV and inactivated. And I believe, I don't actually know the totals of all those different components, but we pretty much had contracts for almost everything.
I think I had Ms. Stinchfield and then Ms. Groom.
Yeah, just Patsy Stinchfield from NAPNAP, just back to the nursing question and what's going on there. I think several things. One, I do think that hospitals know about CMS, and so more organizations are more willing to be strict and firm and even mandating this. Secondly, I think there's much better recording, so we actually know by role who actually is getting vaccinated in hospitals. Third, I think it's many hospitals have either get vaccinated or wear a mask, and mask wearing is not fun, so more people do vaccination. But I also think just, in terms of the splitting and lumping, splitting out groups in your data is much better. I'd ask you to split one more, and that's the nurse practitioners and physician assistants. So I think our data just overall is better too.
Oh, go ahead.
I believe those are split out in the maybe and the MWR. They're not? Okay, that's probably because of sample size issues.
Ms. Groom?
Thanks. Jim, just a quick question on the Healthy People 2021 and the use of the National Health Interview Survey as the data source.
Yes.
In the past, NHIS has used 19 and older, and I noticed that the age grouping is going to look at flu vaccine for 18 and older, so I was just curious about using the NHIS instead of the Burfus data.
Well, the NHIS data, I guess, is considered to be the most representative, since it's an in-person survey with higher response rates than the telephone survey. And so it's considered, the age split it's primarily a matter of convenience and estimation, because the surveys ask different groups. 17 is the cutoff for a child for legal purposes for surveys, and if you're 18 in most states, then you get surveyed yourself instead of the parent. So the data sort of comes with that age split, although, VFC obviously includes the 19-year-olds and the 18-year-olds.
But doesn't the NHIS, does it have data on 18 and older?
Yes,
Okay.
the 18 and over are included, the 18-year-olds are included with the adults.
Thank you very much. I think, keeping an eye on the clock, we'll move on to the presentation by Dr. Greenburg on the Fluzone high-dose influenza vaccine.
Good afternoon. Thank you for giving me the opportunity to present the results from our Fluzone high-dose efficacy trial. I'm pleased to be here. First, I'll start by providing background information on the rationale for developing this vaccine, present key data from our pre-licensure phase 3 safety and immunogenicity study, review results from our recently completed efficacy trial, and tell you about our plans to submit these data to the FDA. In most seasons, people 65 years of age and older account for nearly 2/3 of influenza-related hospitalizations and about 90% of influenza-related deaths. Each year, about 65 to 70% of this population receives vaccine, but studies conducted by the CDC and others have demonstrated that influenza vaccines protect older adults less well than younger adults. This was evident again last season when influenza vaccines offered limited protection against the H3N2 strain among this older population. Relatively lower protection in older adults may be due to immunosenescence, resulting in lower antibody responses. And shown here is a typical example from one of our annual studies in which Fluzone vaccine generated lower geometric mean antibody titers to all 3 strains among older adults, shown in the yellow bars, than in younger adults in the green bars. But the question is whether these lower antibody responses really matter in the prevention of influenza disease. Well, available data clearly point to a clear correlation between resistance to influenza infection and levels of antibody to hemagglutinin. This graph is representative of many that have been published, demonstrating a direct correlation between post-vaccination or post-infection HAI titers and protection against infection upon exposure to influenza virus. So with the preceding facts in mind, Sanofi Pasteur set out to manufacture and license a vaccine that would induce higher antibody titers and provide better protection for this vulnerable population. Fluzone high dose contains 60 micrograms of hemagglutinin per strain, 4 times the amount in Fluzone vaccine. Before presenting the data from our efficacy trial, I'll quickly go over the pivotal pre-licensure phase 3 study that compared the safety and immunogenicity of Fluzone high-dose vaccine with Fluzone vaccine among adults 65 years of age and older. Nearly 4,000 participants were randomized in this double-blind study to receive either Fluzone high-dose or Fluzone vaccine in a 2-to-1 ratio. Solicited injection site reactions within 7 days of vaccination were reported more often among the Fluzone high-dose recipients compared to Fluzone recipients by about 10 percentage points for pain and 3 to 4 percentage points for erythema and swelling. Solicited systemic reactions within 7 days of vaccination were reported by the Fluzone high-dose recipients about 1 to 4 percentage points more often than in the Fluzone recipients. Further, 6-month safety data demonstrated comparable rates of unsolicited adverse events and serious adverse events in the 2 vaccine groups. Post-vaccination geometric mean antibody titers were statistically higher after vaccination with Fluzone high dose, shown in the blue bars, compared with Fluzone vaccine in the orange bars, against all 3 strains. Based on FDA-agreed pre-specified criteria, Fluzone high dose induced superior antibody responses compared to Fluzone for the H1N1 and H3N2 strains, and non-inferiority was demonstrated for the B strain. In summary of the pre-licensure study, Fluzone high-dose vaccine resulted in higher rates of solicited injection site and systemic reactions, but serious adverse events occurred at comparable rates to those after Fluzone vaccine. And importantly, Fluzone high-dose induced statistically higher antibody responses against all 3 strains as assessed by GMTs, seroconversion rates, and seroprotection rates compared to Fluzone. And it met the pre-specified criteria for demonstrating immunologic superiority to the 2 A strains. The FDA licensed Fluzone high-dose vaccine in late 2009 under the accelerated approval process with the hope of providing improved protection against influenza among seniors based on the vaccine's superior immunogenicity. 13 million doses have been distributed in the first 3 seasons of use. But despite the superior immunogenicity, as of last season, only about 19% of vaccinated seniors received this vaccine, largely because healthcare providers and advisory groups have been waiting for the results of our post-licensure efficacy trial. So now I'll tell you about that study. FIM-12 was a blinded efficacy trial of approximately 32,000 community-dwelling individuals, at least 65 years of age, who are randomized to receive Fluzone or Fluzone high dose on a 1-to-1 ratio. Participants were not necessarily healthy, and many did have chronic underlying medical conditions. The study was conducted over 2 seasons, concluding at the end of the 2012-13 season. Participants were enrolled in 126 clinical sites with wide geographic distribution in the US and Canada, as shown here. The primary objective was to compare the clinical efficacy of Fluzone high dose to that of Fluzone against laboratory-confirmed influenza, either defined as PCR or culture positive, caused by any viral type or subtype, associated with the occurrence of a protocol-defined influenza-like illness, which was defined as the occurrence of at least 1 pre-specified respiratory symptom and 1 pre-specified systemic symptom. The secondary objectives included assessment of clinical efficacy based on various clinical definitions, methods of influenza confirmation, and similarity of the case strains to the vaccine strains. And because previous studies have demonstrated clinical benefit of influenza vaccine against certain related complications, including the recent publication in JAMA by Udell and colleagues in Toronto, the observational objectives included a description of pneumonia, cardio-respiratory conditions, healthcare visits, and medication use in the 2 vaccine groups. This slide summarizes the trial design that I've just described. Participants were enrolled and randomized at the beginning of each season, and individuals who participated in both seasons were re-randomized at the beginning of the 2nd season. Passive surveillance was conducted throughout the study, starting 2 weeks after vaccination. Participants were asked to contact study centers if they experienced any respiratory symptoms. Active surveillance involved contacting each participant, also starting 14 days after vaccination. The frequency of contact was weekly through the end of December, twice a week during January and February, and weekly again during March and April. And then a final contact was made in mid-May of each season. A nasopharyngeal swab was obtained soon after, as soon as possible after the onset of a respiratory illness, and no later than 5 days. PCR positive samples underwent genomic sequencing. for assessment of similarity to vaccine strains, and viruses grown in culture underwent HAI testing with ferret antisera for determination of antigenic similarity to the vaccine strains. If both assays were available, the ferret antisera took priority. Participants were similarly distributed between the two vaccine groups with regard to gender, age, racial origin, and ethnicity. Now we come to the most important part of the results. Fluzone high dose met the pre-specified criterion for the primary analysis, demonstrating superior clinical efficacy compared to Fluzone vaccine against laboratory-confirmed influenza associated with protocol-defined ILI by any viral type or subtype, regardless of similarity to the vaccine strains. Fluzone high dose reduced the incidence of clinical influenza by 24.2% compared to Fluzone vaccine. The lower bound of the 95% confidence interval was 9.7%, which is above the FDA-agreed pre-specified limit of 9.1% to demonstrate superior clinical benefit. In the following series of slides, the relative efficacy for the primary objective, 24.2%, is shown in the uppermost table, and the relative efficacies of subgroup analyses are shown below it. Keep in mind that because the number of cases are small in some of these subgroup analyses, the 95% confidence intervals are wide compared to the primary analysis. But as I'll show you, the point estimates are all positive and in the same range. For example, in this subgroup analysis, the clinical benefit of Fluzone high dose was demonstrated across study years, with a relative efficacy point estimates of approximately 45% in year 1 and 21% in year 2. The clinical benefit of Fluzone high dose was demonstrated across influenza types, with relative efficacy point estimates of approximately 24% against type A and 27% against type B. As one would expect, the clinical benefit of Fluzone high dose was somewhat better against influenza strains that proved to be similar to the vaccine strains, with a relative efficacy point estimate of approximately 35%. The clinical benefit was demonstrated across age groups, with relative efficacy point estimates of approximately 20% among participants 65 through 74 years of age, and 32% among those 75 years of age and older. The relative efficacy of Fluzone high dose was slightly higher in the older age group, due in part because of the decreased protection afforded by Fluzone in this older cohort. The clinical benefit was demonstrated across illness definitions, with relative efficacy point estimates of approximately 21% against laboratory-confirmed influenza associated with a modified CDC ILI, which required fever plus cough or sore throat, and 18% against laboratory-confirmed associated influenza caused by, associated with any symptoms of a respiratory illness. And finally, the clinical benefit was demonstrated not only against influenza that was laboratory confirmed by either PCR or culture, which was the primary analysis, but also against influenza that was restricted to culture confirmation, with a relative point efficacy estimate of approximately 23%. Now, switching gears, this and the next two slides show relative risk of developing a pre-specified health outcome within 30 days of the illness associated with symptoms consistent with a protocol-defined ILI, modified CDC ILI, or respiratory illness. In the upper table of each slide, all the cases represent laboratory-confirmed influenza. The number of cases are small, but all of the relative risk ratios are less than 1, suggesting that Fluzone high dose offered better protection against influenza-associated pneumonia compared with Fluzone vaccine. In the lower table of each slide, the illnesses are without regard to laboratory confirmation of influenza. Again, all of the relative risk ratios are less than 1, some significant, indicating that Fluzone high dose offered better protection against pneumonia after any study illness. Undoubtedly, a substantial number of these cases must have been associated with influenza, but the infection was not laboratory confirmed. A similar pattern was observed for cardio-respiratory conditions, suggesting better protection from Fluzone high-dose vaccine against cardiac and respiratory-related complications. Lastly, hospitalizations occurred less frequently in the Fluzone high-dose group compared to the Fluzone group within 30 days of either laboratory-confirmed influenza or within 30 days of a study illness without regard to laboratory confirmation. I'll finish the data presentation with this slide on safety information collected throughout the study period. SAEs included all hospitalizations of any cause, were reported less frequently in the Fluzone high-dose group compared to the Fluzone group, primarily because of the lower frequency of various illness-associated complications, as I just described in the preceding slides. SAEs judged by the investigator to be related to Fluzone high dose were one case each of a left cranial sixth nerve palsy, which started 1 day post-vaccination, a case of hypovolemic shock associated with diarrhea 1 day post-vaccination, and a case of acute disseminated encephalomyelitis 117 days post-vaccination. Adverse events of special interest in the HD group included one case each of Bell's palsy, and a case of encephalitis myelitis, and a Stevens-Johnson syndrome that developed 53, 117, and 160 days post-vaccination. Deaths due to any cause occurred at similar rates in the two groups. In conclusion, the study demonstrated that Fluzone high dose provides superior protection compared to Fluzone vaccine against laboratory-confirmed influenza of any viral type or subtype among seniors 65 years of age and older. Fluzone high dose vaccine reduced the incidence of symptomatic influenza by 24% compared to Fluzone, and the lower bound of the 95% confidence interval met the pre-specified criterion for demonstrating clinical superiority. This clinical benefit was demonstrated across the two study years against type A and type B strains, among participants above and below 75 years of age, against all strains, including those similar to vaccine strains, across various clinical illness definitions, and regardless of the method of laboratory confirmation. In addition, the data of this post-licensure efficacy trial suggest better protection against complications such as pneumonia, cardiorespiratory disease, and hospitalizations. The results of this and other post-licensure studies have consistently demonstrated the safety of Fluzone high-dose vaccine and improved immunogenicity against all three viral strains, confirming the results of the pre-licensure studies. As you might imagine, the FIM12 database is very large, and the project team is continuing to analyze the data. The team's focus for now is to submit a clinical study report to the FDA as soon as possible, no later than early 2014. And at the same time, we'll submit a revised PI containing key data from this trial to support superior clinical benefit. Finally, the team will develop a series of manuscripts from this rich database. I'd like to acknowledge the 32,000 study participants, the 126 clinical sites and their investigators, including Kip Talbot at Vanderbilt, who is the coordinating investigator, and the FIM12 study team at Santa Fe Pasteur, including Carlos Diaz-Granados, the clinical lead, and Vicky Landolfi, the project lead. This in the next slide just lists the current indications and safety information for Fluzone and Fluzone high-dose vaccines. So I'll conclude by emphasizing that this is an extremely important landmark study because it proves once and for all that Fluzone high-dose vaccine provides clinical benefit that is superior compared to Fluzone vaccine in reducing the incidence of clinically relevant influenza compared to Fluzone vaccine in this highly vulnerable population of adults 65 years of age and older. Thank you for your attention. I'll be happy to answer any questions.
Thanks very much for a very nice and concise presentation. I have a quick question for Dr. Brissi here. And just please remind me and perhaps everybody else here what we tend to think of an attack rate for adults aged 65 and older who are not vaccinated. Do we have any good guesses?
Let me look it up and I'll get back to you in 30 seconds.
Okay, other questions? Dr. Kemp.
I have a couple of analytic questions, which is odd for me, but I missed a couple things. First of all, how did you deal with the fact that many people were involved in both seasons and that they may have been randomized to different arms? Secondly, I thought I heard you say that a lot of the clinical outcomes were significantly different when a lot of those risks appeared to cross one, so I'm confused about that conclusion. Thanks.
Sure. So regarding the individuals who participated in both years, that was considered before the trial took place, and there was an extensive analysis to assess whether or not that would somehow skew the results, and in fact, it was shown that it was not expected to occur. So now that the study is over and the groups are unblinded and the analyses are taking place, the analyses for all of these different parameters are being looked at over time with regard to those who did and did not participate both years. Now, it turns out that in fact, many individuals did participate both years, but various things that have been looked at so far, such as the point estimates of relative efficacy, appear to be the same both for those who participated both years as well as those who did not. So there appears not to be any substantial influence of that. Yes, indeed. As I mentioned at the beginning, the study was powered for the primary analysis. And so there's no question that as you get down into these smaller subgroup analyses, there's not going to be enough cases in each group to necessarily have confidence intervals that do not cross one. I think what's important is that despite that fact, the point estimates are all in that general range of 20-30% for most of the analyses. So, could we have done a study of 100,000 people? Well, I suppose over 5 influenza seasons perhaps, but obviously everyone wanted to get results from the study, and the primary endpoint of the number of cases was achieved and study blind and broken and analyzed.
Dr. Karron.
So thank you, David. I have a couple of questions, and the first one relates to clinical endpoints. And I know I've seen your backup slide, and heard your presentation before, and I understand the rationale for not using CDC-defined ILI because fever doesn't always occur in the elderly. But if I understand this endpoint correctly, anybody with a runny or stuffy nose who was found on active surveillance, because there were weekly phone calls, would have counted in the numbers. And I guess I would suggest that what we're probably trying to prevent is, medically relevant illness that gets to the level of going to a provider or something like that. And I was wondering if you have any data on that, and then I have a second question.
Well, the clinical endpoint definition for what we called in these slides as respiratory illness was that situation you described where somebody could have any single respiratory symptom, sneezing, cough, sore throat, and that's all that they would need. But the protocol defined ILI included at least one systemic symptom as well. And the modified CDC ILI it mandated fever greater than 99 and cough or sore throat. So, the full spectrum of illness definitions were used, and so the efficacy, the relative efficacies that were described are quite consistent across all three. Now, when you get to the respiratory illness definition that then eventually is found by PCR culture to be positive, the relative efficacy was a bit lower in that group, in that analysis. I think it was 18% for that analysis, where it was 24% for the protocol-defined ILI. It was similar for the modified CDC ILI. So, we took that into account, and I think by insisting on having at least one respiratory symptom and at least one systemic symptom, and then the CDC mandating that the one systemic symptom be fever, it kind of covers the full range of possibilities.
Okay. And the other question, I know you've heard from me before, but I just thought I would ask again, which is, obviously in the elderly, one of the things we really worry about is duration of protection, and we worry about early vaccination. And do you have any data stratified by time of vaccination versus time of illness to have any, or immunogenicity data to look at durability of the immune response?
Yes, so as I mentioned, this is a very rich database, and the team is continuing to analyze the data. And so some of the results, like I'll answer in a second, just came available in the last couple of days. So didn't get it into the slides, and we'll be happy to share more information with the work group in coming weeks and months. But yes, it was looked at least initially on a breakpoint of 90 days after vaccination. And the clinical efficacy, the relative efficacy point estimate was very similar for disease that occurred prior to 90 days after vaccination and 90 days plus. So at least with that one early analysis, no difference throughout the season, less than or greater than 90 days post-vaccination.
Meaning that so that the relative efficacy was no better 90 days later than...
Yeah, and no worse. So it's not as if you can think of it both ways, but yes, there was no difference.
Dr. Dushin.
Thank you for doing the study. Your mention early on in your methods section about doing the testing within 5 days of symptom onset made me wonder whether there was any difference in the two groups with respect to the timing of their diagnostic testing. That wasn't shown. And then the other question is, are you aware of any other studies of the effectiveness of this vaccine that are in progress or planned, particularly looking at some of the more significant health outcomes? Thanks.
Sure. Well, with regard to the 5-day requirement, all of the culture PCR confirmed cases, the samples were obtained within that 5-day period. I can't say that absolutely. I'd have to go back and see if there might have been a few stragglers beyond 5 days, but that was the study teams across the sites really tried to stick to that requirement. As far as other health outcomes, there are more data in this study, which have not been analyzed yet. So various other outcomes and complications are being evaluated, and how that might relate back to essentially the cost. Not absolute numbers. It's not as if we went into databases to find out what the cost of each of those hospitalizations were, or each of the pneumonias, but certainly we have a very good sense as to those poor health outcomes, and we'll try to translate that in future analyses.
So just as a follow-up, one of the things I've been impressed with as I learn more about influenza is how each influenza season is so different with respect to the viruses that circulate, their virulence, and the relative protection offered by the strains in the vaccine. So you've given us one cross-sectional snapshot of how your vaccine works. And I guess my question is, what are your thoughts about how the two vaccines may compare with respect to the influenza B and A components over a number of years, because particularly with better immune response to the B component, and we're having more appreciation of the impact of type B disease on adults, how those two vaccines might compare. Might there be something different than what we're seeing in this presentation?
Well, certainly, as you say, every season is different. The nice thing about this study and the 2 seasons that the study covered was they were very different. It's amazing how different the two seasons were. So the first season was, as I recall, being described here at ACIP by the CDC as the lightest influenza season essentially on record. And yet, you may know from other influenza studies conducted over the decades that sometimes one finds no difference or no clinical benefit of influenza vaccine when it's a very light season. And yet, in fact, in this study, great clinical benefit was described. So that, I think, was a nice offshoot of the study. And then the second year, which was, of course, a very heavy year, but but the strain, such as the H3N2, was not necessarily greatly matched to the vaccine strains, we still showed additive clinical benefit of the high-dose vaccine compared to Fluzone. The A and B strains, as I demonstrated, the data seemed to indicate that that protection was afforded to both A and B strains. When we look at similarity to the vaccine strains, a greater clinical benefit of Fluzone high dose was demonstrated when the circulating strains matched the vaccine strains. So, were these 2 seasons representative of all seasons? Perhaps not, but I think we had a great comparison here of 2 seasons that were quite different, and that relative efficacy held up in both years.
Dr. Rengold.
A very nice study. I suspect you'll be telling me that these results are forthcoming, but two related questions. One is, obviously, people over 65, you have a fairly diverse group, some of whom are quite healthy, many of whom may have underlying illnesses. So I wonder if you can tell us something about the clinical protection and its variation by how sick these people were at baseline, and whether you have good, I assume you're going to be looking at correlates of protection, and what you can tell us about the immune response in those sicker elderly in terms of whatever the right correlative protection is in the study.
Well, certainly. So the first question about how ill the participants were, as I mentioned, we did include, or we did collect information on comorbidities, and so at least early analyses have already been done, but again, didn't have time to get them into the slides, that the relative efficacy of the high-dose vaccine compared to Fluzone was the same, very similar among participants who did not have comorbidities and those who did. And many of them did. 2/3 of the participants had at least one influenza-related comorbidity, and 1/3 of the subjects had 2 or more comorbidities. Immunogenicity, so both immunogenicity and clinical effectiveness, clinical efficacy, relative efficacy were the same among those who had comorbidities. So at least within this context, it looks like the protection is provided in both. Yes, there will be analyses looking for correlates of protection. That's one of the aims of the study. Those analyses have not yet been done. And by the way, in terms of how the vaccine performs among even sicker individuals like those who are in long-term care facilities, Rick Zimmerman, who I think most of the panel know, presented at ID Week, the study done at the University of Pittsburgh and nursing homes and long-term care facilities in their area, showing, again, superior immunogenicity of the Fluzone high dose compared to Fluzone vaccine. That's not an efficacy study, but they followed safety, which was fine, and then superior antibody responses.
Dr. Lair.
2 quick questions. One very simple one. Are you working on a quadrivalent high dose?
Yes. So we recognize that the high-dose quadrivalent vaccine is something that people are going to be expecting, and there are clinical studies that need to be conducted, but we have it in the clinical development program, and yes, we're planning to do that.
And my second question was just checking my math. If I'm doing the math correctly on slide 19, it looks like for every 1,000 people vaccinated with high-dose flu versus regular Fluzone, you'll have 4.6 fewer cases of flu. Is that math correct?
Yes, so you're comparing these, do I have it on the right slide?
Yes.
So you're comparing these 2 groups. So the incidence of laboratory confirmed influenza for the 2 groups is, as you pointed out, about 1.4 and 1.9 cases percent, so percentage shown on the slide. So yes, so there's a diminution of the number and incidence rate of influenza in the high-dose group compared to Fluzone. Now, of course, what's not here is a placebo group. There was no placebo group in the study.
Right, but just to comparing high-dose versus Fluzone,
right.
For every 1,000 doses, you'll have 4 to 5 fewer cases of flu.
I have to check the math. It looks right, but yes, something in that order.
Thank you.
Any other questions out there, comments? Quick question, did we have any estimate? I'm sorry for that, but
my
it's
deer
just...
in headlight stare is just because of my advancing age. So if you want to compare it to that, we don't have active good estimates of ongoing estimates of rates of disease or clinic-based disease, lab-confirmed disease among the elderly from our surveillance systems. We do survey for hospitalizations clearly, and think about over the last 10 years a rate of hospitalizations among the elderly of about 1 per 1,000. Last year it was 150 per 100,000, for instance. What we know from the early studies that are community studies in the early 70s was the annual rate of overall influenza is about 5 to 15 or 20% of the population, and we certainly know that in the elderly people, the rates of disease, of acquisition of disease, are on the low end of that. And so, if you compare it to this, I don't know the real answer, and we'll dredge it up and send it around to the ACIP. But think about the 5% range or so annual attack rate. I'm making this up a bit, and as long as it's not being recorded, I'll be happy.
Yeah, the recording people went home at 1 o'clock, so you're off the hook. Quick reminder, the February registration is live and functioning, so for the upcoming meeting. And if there's no further comment or discussion, I wish everybody happy travels on your way home, and thanks for your attention and attendance.